Ladies and gentlemen, dear colleagues, good evening. First of all, I would like to thank Pfizer for sponsoring this meeting endorsed by the IADA. My thanks also are extended to ICOM team for facilitating all the technical procedures. I have the great pleasure and honor to share moderating this meeting with my dear friend and colleague, Professor Talat Abdelati, head of the Internal Medicine Department at Alexandria University. This evening, we shall be listening to 5 eminent speakers. From Italy, my dear friend, Professor Paolo Pozzilli, and Professor Napolo Nicola. The national speakers are Professor Iman Youssef, head of the Diabetes Metabolism and Lipidology Unit, and Professor Kamel Hamida, and Professor Noah Gaber. Both are from the same unit. Now I give the mic to my dear colleague, Professor Talat Abdelati, to present the first speaker. تفضل أستاذ طلعت.
Good evening. I would like to thank Pfizer again and ICOM again. I have the pleasure to be with my dear professor, my dear brother, my dear father, Professor Fahmi Amara, and I have the honor to introduce.
صوت الأستاذ طلعت مش طالع خالص يا جماعة.
I would like to thank Pfizer and for sponsoring this meeting. Also, I would like to thank ICOM for preparing this meeting. I have the honor to be with my Professor Fahmi Amara and my father again. Also, I have the honor to introduce Professor Iman Youssef. Professor Iman Youssef is the head of Diabetes, Lipidology and Metabolism Unit, Alexandria University. Professor Iman is the dynamo of the Internal Medicine Department. Professor Iman will talk about microvascular diabetic complication. Please proceed.
بسم الله الرحمن الرحيم. أشكر أستاذي الفاضل الغالي الأستاذ الدكتور فهمي أمارة، وأشكر أستاذي الفاضل الغالي أستاذ الدكتور طلعت عبد العاطي رئيس قسم الأمراض الباطنة. Thanks for Pfizer and ICOM. My talk about microvascular diabetic complications. Starting by the most important slide, that tight glycemic control would prevent the development and or ameliorate progression of diabetes-associated microvascular complications, both in type 1 and type 2 diabetes. This is because hyperglycemia is the main and the only player in the pathogenesis of microvascular complications. Diabetic retinopathy. The prevalence of diabetic retinopathy is strongly related both to the duration of diabetes and the level of glycemic control. Diabetes is the most frequent cause of new case blindness in the developed countries. Stages, starting by the mild stage, which is called mild non-PGR. These changes occur 3 to 5 years after the diagnosis of type 1 diabetes. The earliest signs, which are called soft and hard exudate, and usually the visual acuity is unaffected. With more progression of the microhemorrhage and microaneurysm, there is moderate and severe degree called moderate and severe non-PGR. At 5 years, mild, moderate, severe non-PGR are associated with risk progression of PGR by 15, 30, and 60% respectively. The worst stage is called PGR, which is characterized by new vascularization either in the retina or in the vitreous body, which is called high-risk PGR that lead to retinal detachment, retinal hemorrhage, and blindness. Management. General recommendations to reduce the risk or slow progression of retinopathy. We should have tight glycemic control and tight blood pressure control. All we know, the tight glycemic control, A1C should be below 7%, preprandial ranging from 80 to 130, and 2 hours postprandial should be less than 180 milligram per deciliter. Tight blood pressure control, systolic blood pressure should be reduced to below 140, and diastolic should be reduced to below 90. Screening. What is the time of fundus examination? Fundus examination is recommended within 3 to 5 years of diagnosis of type 1 and at the time of diagnosis of type 2 diabetic patients, because most of them are accidentally discovered. Subsequent fundus examination in both types of diabetes should be repeated every year. For patients with pre-existing type 1 or type 2 diabetes in pregnancy, fundus examination should occur in the first trimester with close follow-up through pregnancy every trimester and even for 1 year in the postpartum period. Telemedicine program that use validated retinal photography with remote reading can be an appropriate screening strategy for diabetic retinopathy. Treatment. First, I should treat medical problems associated with accelerated retinal damage, such as hypertension, dyslipidemia, nephropathy, and pregnancy, because retinal pathology shows rapid progression. Laser photocoagulation is indicated to reduce the vision loss and are indicated mainly in high-risk PGR, some cases of severe non-PGR, and diabetic significant macular edema. Monthly intravitreal injection of anti-vascular endothelial growth factor is indicated in diabetic macular edema that may threaten reading vision. Take care. The presence of retinopathy is not a contraindication for aspirin therapy, which is used in diabetic patients for cardioprotection. This is because aspirin does not increase the risk of retinal hemorrhage. Second, microvascular diabetic complication is diabetic kidney disease, which occurs in 20 to 40% of patients and is the leading cause of end-stage renal disease in USA. CKD typically develops after diabetes duration of 10 years in type 1, but may be present at diagnosis of type 2 diabetes. Although end-stage renal disease may be the most recognizable consequence of DKD, the majority of patients actually die from cardiovascular disease before needing kidney replacement therapy. It was found that the level of glycemia and glycosylated hemoglobin seems to be the strongest factor affecting the onset of appearance of albumin in urine. But still, hypertension, cigarette smoking, dyslipidemia, and genetic susceptibility are several important risk factors beside hyperglycemia that affect the development of several stages of diabetic kidney disease. So, The link between diabetes and chronic kidney disease arises from a common soil which contains hypertension, atherogenic dyslipidemia, endothelial dysfunction, hypercoagulable state, chronic low-grade inflammation, and oxidative stress. Diagnosis of diabetic kidney disease. It is usually a clinical diagnosis based on the presence of long-standing duration of the diabetes, as we said, 10 years, retinopathy, albuminuria without hematuria, gradually progressive decrease in the estimated GFR, in the absence of signs and symptoms of other primary causes of kidney damage. However, reduced estimated GFR without albuminuria has been frequently reported in type 1 and type 2, reaching a prevalence of 50%. This is called non-albuminuric diabetic kidney disease. Also a typical presentation that signs of CKD may be present at diagnosis or without retinopathy in type 2 diabetic patients. Screening. Patients with type 1 diabetes should be screened for albuminuria every year, 3 to 5 years after diagnosis, while patients with type 2 should be screened yearly but early, starting at the time of diagnosis of type 2. We ask the patient to do urinary albumin creatinine ratio, estimated GFR, periodic monitoring of serum creatinine and potassium, especially in patients receiving medications of ARBs and AC inhibitors. There is a biological variability in the excretion of the urinary albumin. So, 2 of 3 specimens collected within 3 to 6 months period should be abnormal before considering a patient having albuminuria. Take care that exercise 24 hours before the test, severe infection or uncontrolled heart failure or uncontrolled hyperglycemia and hypertension may elevate the urinary albumin excretion, so this can give false positive results. Historically, the definition of albumin excretion abnormality was micro and macroalbuminuria, but the new classification is very useful in treatment. Normal, in which the urinary albumin creatinine ratio below 30, and increased urine albumin excretion, in which it is above or equal 30 milligram per gram creatinine, and this need spot collection of urine. Don't forget that you should refer a case to a nephrologist in the stage 4 CKD when the estimated GFR is below 30. This found to reduce cost, improve quality of life, and delay dialysis. Treatment. Number 1, tight glycemic control. I repeat again for its importance. A1C should be below or around 7 in most of cases. Preprandial should be ranged from 80 to 130. 2 hours postprandial should be below 180. This found to reduce the risk or slow progression of chronic kidney disease. Number 2, sodium glucose cotransporter 2 inhibitor or glucagon-like peptide 1 receptor agonist for patients with type 2 diabetes and CKD found to reduce the risk and slow progression of chronic kidney disease and cardiovascular events in such patients. Number 3, in non-pregnant patients with diabetes and hypertension, use either AC inhibitor or ARBs. Recommended for patients having elevated urinary albumin creatinine ratio more than 30. So don't wait until it is above 300. just above 30, you should start renoprotective drugs. Take care that there is no primary prevention for diabetic kidney disease. This means that AC inhibitor or angiotensin receptor blockers are not recommended for the primary prevention of diabetic kidney disease. This means that patient has normal blood pressure and normal albumin creatinine ratio below 30, don't use these drugs as a primary prevention. The fourth item in the treatment, patient with non-dialysis dependent CKD in this stage, the dietary protein intake should be approximately equal to the recommended daily allowance. While for patient on dialysis, higher level of dietary protein should be considered. Finally, diabetic neuropathy. It is a very common complication of diabetes, affecting about 50% of patients or more. It is a diagnosis of exclusion, particularly the diabetic peripheral neuropathy, that involves presence of symptoms or signs of peripheral nerve dysfunction in diabetic patients after exclusion of other causes of peripheral neuropathy. Diagnosis. Symptoms vary according to the class of the sensory fiber affection. The earliest symptoms هي small fiber affection, patient complaining of pain, usually burning or tingling. But with affection of large fibers, the patient complaining of numbness and loss of protective sensation. This loss of protective sensation indicates that this patient have distal symmetric sensory motor polyneuropathy, which consider the most common neurological complication of diabetes. This condition is sensory motor, so superficial sensation is affected. There is stocking glove paresthesia of distal extremities. Deep sensation is also affected in the form of absence of joint sense and vibration sense. There is motor affection in the form of distal muscle wasting and loss of deep tendon reflexes both in the upper and lower limbs. And there is loss of coordination. This is called sensory ataxia. The most common complications of this neuropathy is Charcot joint and foot ulcerations. Diagnosis. Clinical tests should be done to assess small and large fiber function. For example, 10-gram monofilaments, vibration perception, pinprick sensation, and deep tendon reflexes. In the case of 10-gram monofilament, apply the monofilament at right angle of the skin. Then apply pressure until the monofilament buckles, and the patient should recognize the perception of pressure and identify the correct site of pressure. Screening. All patients should be assessed for diabetic peripheral neuropathy, starting at diagnosis for type 2 and 5 years after in type 1, and should be assessed every year. The signs and symptoms of autonomic neuropathy should be carefully elicited by history and physical examination, stressing on diagnosis of hypoglycemia and awareness, orthostatic hypotension, gastroparesis, neurogenic bladder, and pseudomotor dysfunction. Treatment. Tight glycemic control can significantly prevent or delay the development of diabetic peripheral neuropathy and or cardiac autonomic neuropathy. In type 1 patient, and slow progression in type 2. But take care, tight glycemic control does not reverse neural loss. Number 2, reduce pain related to the diabetic peripheral neuropathy to improve the quality of life. Either pregabalin or duloxetine are recommended only as an initial pharmacological treatment for neuropathic pain in diabetic patients. Pregabalin, use 50 mg every 8 hours, maximum dose of 300 mg per day. Duloxetine, either use 60 or even 120 mg once daily. Finally, you should manage diabetic autonomic neuropathy and you should do diabetic foot care. Thank you.
Dr. Iman for this excellent presentation as usual. غطت كل المايكروفاسكولار complication of diabetes. I will leave and استاذ فهمي حضرتك بقى ايه تولى الاجانب. استاذ فهمي حضرتك سمعنا؟
سمعك خالص يعني همس.
اتفضل.
همس. طيب. شكرا دكتور إيمان. Now I have the pleasure to invite Professor Paolo Pozzilli, is our friend, to give his talk about diabetes and dyslipidemia treatment. Yes. Good evening, Dr. Pozzilli. It's a pleasure to meet you again. And dear colleagues, I have the pleasure to present our dear friend, Professor Paolo Pozzilli. His talk will be on diabetes and dyslipidemia treatment. Please, Dr. Pozzilli, you can start.
Good evening, Professor Famiamara. It's a nice occasion to be together again, although virtual, but you are good friends, and I really like to thank the Pfizer and ICON for organizing this interesting session on diabetes complication and dyslipidemia. I start my presentation showing the disclosure. This is my conflict of interest. Now, what about diabetic dyslipidemia? Diabetic dyslipidemia is not a simple dyslipidemia because it's associated with the presence of hyperglycemia. And per se, dyslipidemia and hyperglycemia together create a very dangerous occasion that could really create serious problem where combination of typical microangiopathy and macroangiopathy can live together in the same patient. We have to say that dyslipidemia is very common in type 2 diabetes, and approximately 70% of patients have dyslipidemia with diabetes. Treatment of diabetic dyslipidemia can be regarded both from a non-pharmacological point of view and pharmacological point of view. I will briefly discuss the non-pharmacological treatment that include nutrition therapy, weight loss in particular, and physical exercise. Now, generally, we all know that diabetic patients should increase the intake of stanol sterols, biscuit fiber, and decrease the intake of saturated and trans fatty acids. The American Diabetes Association, after the very relevant paper published in the New England that I'm going to show briefly in a couple of minutes, suggested that the Mediterranean diet, and I'm very pleased to say the Mediterranean diet because both in Italy and in Egypt, we live in the Mediterranean. So the Mediterranean diet is now considered together with the DASH dietary approaches to stop hypertension diet, the two ideal diets to use in patients that are diabetic and they have cardiovascular, or they don't have cardiovascular disease, but they are at risk of cardiovascular disease because they have hyperlipidemia. Then the consumption of a rich diet in walnut in a randomized study show improvement on non-HDL cholesterol and apolipoprotein B. And in general, a reduction of 5% in body weight is associated with an improvement in lipid profile, insulin resistance, and glycemic control. this is the PREDIMED trial, and the PREDIMED trial was designed to find out how Mediterranean diet can prevent myocardial infarction, stroke, or death from cardiovascular causes. So that this was the primary endpoint, that you can see the results on the left, the controlled diet versus the Mediterranean diet, and you can see the reduction in the primary endpoint. And on the B panel, you can see the total mortality, and you can see that the Mediterranean diet indeed can reduce mortality in patients at high cardiovascular risk, and then we can see the effect of the Mediterranean diet that is heavily supplemented with extra virgin olive oil compared to a reduced fat diet. So that is the diet that we should recommend to our patients. But that is not enough. And indeed, if you look at this very relevant study published a few years ago in The Lancet, the Look Ahead study, the Look Ahead study looked at the cardiovascular effect of intensive lifestyle intervention in type 2 diabetes. And as you can see, this study showed that in patients that were followed for 10 years, so a long period of follow-up, the intensive lifestyle intervention does not reduce the risk of cardiovascular morbidity or mortality as compared with a control program where they support education and controlled body weight. So that is a typical demonstration that a non-pharmacological approach in patients that are at risk of cardiovascular disease or they had already a primary cardiovascular event is not sufficient to control the dyslipidemia in these patients. So that is the main comment from the Look Ahead trial, saying that based on the results of this study, there is the need for pharmacotherapy along with lifestyle modification to reduce the cardiovascular disease. So what about pharmacological treatment and dyslipidemia? Now, I'm sure you are all familiar with this drug, the statin, the ezetimibe, the new PCSK9 inhibitors, and the bile acid sequestrants. Now, the mechanism of action is well known to all of you. The clinical efficacy, we can summarize that the statin are really highly effective, but the adverse events associated with the use of this drug are well known and can really jeopardize the potential effect that this drug have in controlling hyperlipidemia. The ezetimibe is moderately effective and can be added to statin therapy, but the PCSK9 that have been recently introduced in the last couple of years are very highly effective in combination with statin therapy in particular, whereas the bile acid sequestrant are moderately effective. So if you look at the cost-benefit ratio, and in particular, I say the cost-benefit ratio, the statins remain the drugs of choice in patients with dyslipidemia and diabetes, in particular to prevent the cardiovascular complication associated with an increase in LDL. But we have to consider that the world of statin developed at the beginning of 2000. Around 2002, 3, 4, and 5, the CART study and other study clearly showed that statins can delay the progression towards a secondary events in patients that already have cardiovascular disease, or also prevent primary cardiovascular disease. But then what's happened in the history of diabetes associated with dyslipidemia? The introduction of the SGLT2. That actually the SGLT2, the first study that was published in 2015, the EMPEREG, demonstrated an effect in terms of reduction of cardiovascular mortality and mortality for all cause of about 40%. So that changed completely the approach. And now the diabetologists play a major role compared to the internists, because in the beginning, statins was really something that we diabetology have taken from the internists, and now the cardiologists are taking the SGLT2 into their world because they found, and recently at the ESC, they show clearly an effect in prevention. New studies show the effect in preventing heart failure. So the combination now of statin and SGLT2 are creating a new approach to the treatment of dyslipidemia and hyperglycemia, because we have to remember that our patients are hyperglycemic and we need to control glycated hemoglobin in addition to prevent cardiovascular disease. So that is created a very unique field where we have to think seriously about how these patients should be treated in combining different drugs. Now, I think that this slide that is taken with my comments, taken from a paper published just this year on the Canadian Journal of Diabetes by Lazare et al., it says really a nice approach to the pharmacological management of dyslipidemia in diabetes. So there is no question that, as you can see here from the triglyceride level, that greater than 10 millimolar, we're talking about 800 milligram, just to refresh your memory regarding millimolar and nanogram, triglyceride greater than 800. And when we're talking about LDL and less than 2 nanomolar and less than 1.5 nanomolar, we're talking about 77 and 55 milligram deciliter of LDL. So what I think is important is that clearly statin remains the cornerstone of drug therapy to prevent macrovascular disease. Then we have the add-on to statin or ezetimibe, and appear particularly beneficial in patients that have high risk for diabetes, and studies have shown that. And then the introduction of the PCSK9 reduced the cardiovascular risk in statin-treated patients, and an effect that is magnified in absolute term in patients and with diabetes. And high dose omega-3 may be a worthwhile consideration to add in these patients. The statin and recommended dose, there is a speaker after me that is going to talk about statin. Definitely Dr. Gaber will discuss that later on, but this is a summary of what is the present state of the art regarding the use of statin at high intensity dose, the atorvastatin 40 to 80 milligram, the rosuvastatin 20 to 40, and as you can see here, all the other moderate intensity statin, and this is the guidelines recommended by the Association of Clinical Cardiologists, the American Heart Society, and the American Diabetes Association. But then I think this is a slide that can tell you really how we can calculate the benefit from a lipid lowering intervention. Now, if you look at the recent, the 2009 European Society of Cardiology and the European Atherosclerosis Society to propose an algorithm to anticipate the expected clinical benefit of any kind of lipid lowering therapy that is based on the intensity of therapy and the benefit risk. So if you look at that, you can see that the benefit on lipid lowering therapy is proportional to the absolute change in the LDL and other ApoB containing lipoproteins. But that change must be interpreted and investigated in the context of somebody baseline level of risk. Because if you look on the left on this slide, the moderate intensity statin, the high intensity statin, and the average reduction, we have to calculate based whether this is a treatment that is decided for primary or secondary prevention. And of course, that needs to be taken into account when we consider in our patient the use of different compounds. And as you can see, the PCSK inhibitor plus high intensity statin could have an average LDL reduction of about 85%. So make a calculation if you have a patient with 150, 200 milligram deciliter of LDL with an 85% reduction of that value, you can reach value around 70 to 80 milligram deciliter. So I think that this could help when we try to figure out how we want to reduce the LDL in our patients, considering the different drugs and their capacity to lower LDL. Looking also another aspect that the physician should take into account, that is the relative prevalence of the main times of adverse effects reported with statin therapy. I'm sure you are familiar with these complications, but I just among all those, regarding statin therapy and the muscle symptoms that are well known, just about this glycemia and new onset diabetes that has been reported. And you may say, how is that dysglycemia, new onset diabetes may occur in patients treated with statin? The Jupiter study in the past investigated this particular aspect and found a 9% increased risk of diabetes in patients treated with statin. But then another thing that we have to keep in mind, that these patients that have increased LDL may be treated with SGLT2. And then by using the SGLT2 and the statin as well, that don't forget the statin have a very strong anti-inflammatory process, and that could be a way to control the evolution towards diabetes and potential effect of statin in causing few cases of diabetes. So we have to remember that statin have this effect that may be beneficial. So I finish my presentation with few words on the PCSK9 inhibitor and its mechanism of action. Now, we all know that the PCK is a protein that is produced by in the hepatocyte, and then secreted into the extracellular space. And this protein binds to LDL, the receptor particle, and then is internalized via the endocytotic process into the hepatocyte. When the PCK is present in that complex that occur when the receptor is targeted via the endosome to the lysosome for degradation, we have an effect in reducing the LDL. So this is a very strong effect, very potent, the use of this monoclonal antibody inhibiting the PCSK9. And two pivotal studies have been published in 2018. The two studies I'm sure you are familiar with are the Fourier study and the Odyssey outcome that demonstrated that both antibodies reduce major adverse cardiovascular events in high-risk patients for cardiovascular complication. And these are the results. You can see in red the Fourier evolocumab, and in the Odyssey in blue the alicumab, and then you see versus placebo that is in red on top, and then the other line for the other trial. And as you can see, the striking effect of this monoclonal antibody to reduce LDL. And so these results were accepted very favorably by the diabetes community and by the cardiology, and is still in the early phases because we do not know about the long-term potential risk of these drugs. So we have to wait more safety study, but also the cost of this study have been presented and commented in many occasions. And here altogether, you can see the results for the two trials in regarding the primary endpoint, the triple composite endpoint of cardiovascular complication. And then you can see the myocardial infarction, the stroke, the coronary vascularization, the cardiovascular death, and all-cause death. So clearly, these monoclonal antibodies have created new opportunity to prevent cardiovascular complication. However, studies are ongoing, new studies, and definitely we will see many more results in the coming year. So I conclude my presentation by saying that the statin still remain the cornerstone of treatment with dyslipidemia in patients with diabetes. And for the majority of patients, the lifestyle, yes, remain first line together with statin. And I think that we cannot consider lifestyle changes alone as a way to control hyperlipidemia, dyslipidemia in patients with diabetes. The statin-associated muscle symptoms still remain a residual risk, and mainly represent the reason why some patients actually stop using these drugs. And now there are also many other lipid-lowering medication, and among those I just mentioned the PCSK monoclonal antibodies that have shown the proven benefit on CV outcome. And then the long-term safety, as I said, about the PCSK9 should be evaluated, and the price that is very expensive at present should be come down to be really cost effective as we would like to see. Thank you very much for your attention.
Thank you very much. Thank you very much, Dr. Pazzilli, for this elegant and clear lecture. صوتي مسموع يا جماعة. About different modalities in treating diabetic dyslipidemia. Thank you very much.
Thank you.
Our second speaker tonight is Professor Nicola Napoli from Italy, and his talk will be on risk of hypoglycemia. Very fruitful. We feel actually sensation of hypoglycemia is a very bad, and we have to avoid it for our diabetic patients. Please, Dr. Napoli, you can start.
Thank you, Professor Fahmy, and I would like to thank the organizing committee and ICON to have invited me. And I will try to give you some input on the risk of hypoglycemia and consequences of hypoglycemia in diabetic patients. As you know, the hypoglycemia is the major limiting factor in the management of type 1 and type 2 diabetes. And hypoglycemia remains a major limiting factor for a successful glycemic management, despite the availability of prevention options such as insulin analogs, continuous glucose monitoring, and insulin pumps. So hypoglycemia is still a barrier for achieving good glycemic control, what we believe is the target of glycemic control for our patients. So non-severe, that are basically the self-treated, and severe, basically requiring assistance for recovery, hypoglycemia rates are higher in patients with type 1, but also those patients on type 2 diabetes, mostly those on insulin or on sulfonylureas, are at risk of hypoglycemia, and I will go more in detail in the next slides. So in order to define the risk of hypoglycemia, we have threshold values, and we discuss about to have a level first, and this is a condition called alert value, where glycemia is lower than 70 milligrams, but sufficiently low for treatment with fast-acting carbohydrates and dose adjustment of glucose-lowering therapy. At level 2, we have blood glucose that can go down up to 54, but sufficiently low to indicate serious and clinically important hypoglycemia. Finally, we have the severe hypoglycemia, the most important condition, because severe hypoglycemia can cause a severe cognitive impairment, requiring external assistance for recovery. These are the threshold values that have been indicated by the American Diabetes Association according to the standards of medical care in diabetes in January of this year, in 2020. And then, of course, we have several ways to treat our patients, and we have different indications according to the American Diabetes Association or according to the ISPAD, which released different guidelines to treat hypoglycemia, but basically are very similar. Using, of course, glucose that can be used as oral or by in case of basically mild hypoglycemic events, or of course in terms of IV glucose when hypoglycemia is more severe. Then we have glucagon. Glucagon is important because we have new ways to administrate glucagon, mostly from with the intranasal devices that are actually very new and even still a little bit expensive, but in the market we have a new formulation, new devices that are able to quickly improve glucose levels. And this is very important mostly in the kids with type 1 diabetes. Of course, we can give glucagon also through injections with the intramuscular or subcutaneous administrations. But the most important part comes from the education. We need to educate patients. We need to educate our patients in the clinic to the management of hypoglycemia, and mostly to avoid the hypoglycemic events. And this is very important in terms of lifestyle, in terms of food frequency, food intake, carbohydrates count. There are several things that, of course, make the difference when we spend time to educate the patients. And importantly, the risk assessment. This is usually the part of our screening of hypoglycemia that is totally neglected in the clinic, because we are always running in the clinic, we are always late, patients complain because they wait in the waiting room, and often we never ask to patients how often they suffer of hypoglycemia, and in case they experienced any hypoglycemic events, if these have been severe or mild. So it's extremely important, again, that besides the treatment of the symptoms through glucose or through glucagon, we need to educate patients to the management and to prevent hypoglycemic events. And this is very important when we see patients in our clinic, to spend time, and again, with the risk assessment and then with the education. And of course, who are more at risk? Which are the risk predictors of severe hypoglycemia? Treatment with the sulfonylureas. So we are still in the group of patients with type 2. Patients with type 2, but on insulin treatment, and the risk is much higher in those patients with more than 5 years of disease and with more than 5 years of treatment with insulin. And then patients on insulin treatment, but who are type 1 diabetic patients. And the risk is much higher in those patients with more than 15 years of treatment with insulin. But again, so type 1, of course, are the patients who are at a higher risk of hypoglycemic events. Now we can determine the risk level for severe hypoglycemia. It becomes low risk when the hypoglycemic events are less frequent. So we are talking about less than 3 episodes per week. And mostly the hypoglycemia awareness is still good, and the patients are able to recognize an hypoglycemia when levels are above 54. Risk becomes moderate when the hypoglycemic events are more frequent, so more than 3 episodes per week, and patients have a reduction in the awareness of symptoms. So they start to feel hypoglycemia when blood glucose is lower than 54. And then patients at high risk are those with a long duration of treatment, long duration of insulin treatment, are patients that with frequent events of hypoglycemia, more than 3 per week, and mostly they have an impaired hypoglycemia awareness. So they don't feel the symptoms. They don't feel to be in the hypoglycemia range. So these are the patients who are at higher risk because they may suffer the acute consequences of hypoglycemia that we will see in the next slides. So according to the National Institute of Health in the US, the NIH, there are medications that are very important that should be avoided because can occur as a side effect of some diabetes medication. So hypoglycemia can be the consequence of some diabetes medication, including insulin, oral diabetes medications like glimepiride, glipizide, gliburide, repaglinide, and glibenclamide. These are very, very widely used medications, mostly from GPs. They like a lot because are cheap, are fast acting because they drop blood glucose very quickly and are very efficient. The main problem, of course, of these medications is the risk of hypoglycemia, and mostly patients on these medications, usually they need insulin treatment much before the medications more modern and like GLP-1s or SGLT2. So there is a higher risk of developing insulin need than other medications. But important is also an economic burden that we need to discuss, because it's a huge cost for the community. It's a huge cost for taxpayers to sustain the expenses of hypoglycemic events. In the US, in the 2005, all the hypoglycemic events cost a total of 3.5 billion. That dropped to 1.84 in 2009. And the reason is likely because of the large use of glargine and the lower use of some other forms of insulin that cause more often hypoglycemic events, and similarly also for the less use of sulfonylureas with the entrance in the market of GLP-1s and DPP-4 inhibitors that were released in the United States in 2006. This is an Italian study that has evaluated the cost of hypoglycemic events when patients were admitted in the emergency department, and screening more than 3,000 patients with hypoglycemic events, severe hypoglycemic events, again with access to ER, to emergency department. Half of these patients were on insulin, 8.5% of these patients were on sulfonylureas, becoming basically the most risky medication among the oral agents. And half of these patients were already suffering of cardiovascular disease. This is very important because an hypoglycemic event can trigger another heart attack, can trigger an arrhythmic episode, so it can be lethal. And again, the risk is much higher if the patients have already a cardiovascular risk and they have suffered of heart attack or any other cardiac clinical conditions. Overall, the cost of in a severe hypoglycemic event is about, in Europe, 6,000, just putting together the cost of ambulance, treatment, cardiology, consultant, etc. So any severe event of hypoglycemia costs 6,000 euros. There is a huge cost for the community, for the society. And the cost is much higher in elderly people, reaching compared to what happens in younger people. And now let's look carefully what happens if our patients develop an hypoglycemia. It's very important to distinguish what can happen during the day and what happens during the night. So during the day, an hypoglycemia can mostly trigger a sympathoadrenal activity that dominates over the parasympathetic activity, with an increase of epinephrine secretion and lower potassium level. And the final consequence is tachycardia, atrial and ventricular ectopic beats, with an increased risk of arrhythmias such as atrial fibrillation, or ventricular fibrillation, that is basically a lethal condition. In case of hypoglycemia occurring during the night, we have an attenuated sympathoadrenal activity with lower epinephrine secretion, an increased compensatory vagal activation. We have a bradycardia, atrial and ventricular ectopic beats, but in this case, we have an increased risk of ventricular arrhythmias and of cardiac arrest. So these are the opposite conditions that can happen if hypoglycemia occurs mostly during the night or during the day. And of course, if during an hypoglycemic event, the most important event, again, is related to the possibility of vasoconstriction of the coronaries, and again, the occurrence of an heart attack with an ischemic event that can be fatal for the patient. And another important aspect that is often neglected and never considered is the risk of dementia. This is a very important study published on JAMA a few years ago, showing that a progression and a progressive increase in risk of dementia according to the number of hypoglycemic events. So if a patient suffers of, in average, one episode per week we have basically an increase by 168 in terms of odds ratio for developing dementia, but the risk becomes 2.60, so basically it's doubled if patients suffer 3 or more events, 3 more of hypoglycemic events per week. So this is very important to prove how hypoglycemic event can be fatal, can be lethal for the heart, but can be very important also on the long term on developing dementia. And then these are our data we published a few years ago, analyzing the Mr. Ross cohort, showing how sulfonylureas use, mostly because of the hypoglycemic events that may cause, are medications that increase also the risk of fractures. We should not forget that hypoglycemia often means falls, and falls means fractures, hip fractures, mostly in the elderly people. So, according to this editorial on the New England Journal of Medicine published 1 year ago, so it's very clear that the sulfonylureas and other insulin secretagogues for treating type 2 diabetes patients are recognized to cause hypoglycemia. All glucose-lowering drugs can potentially cause hypoglycemia, particularly in circumstances in which patients has stopped eating during an intercurrent illness. However, the frequencies of hypoglycemia, almost entirely non-severe, that have been reported with new classes of oral and injectable glucose-lowering drugs like GLP-1 or DPP-4 inhibitors, SGLT2 inhibitors, are very low. And the increasing use of these agents in preference to sulfonylureas should help to minimize the risk of low blood glucose levels and its consequences, particularly in the vulnerable groups such as the frail elderly. And importantly, for patients with type 2, sulfonylureas are the oral agents that pose the greatest risk for iatrogenic hypoglycemia, and the substitution with other classes of oral agents or even glucose-like peptide-1 analogs should be considered. This is a report of the working group of the American Diabetes Association and the Endocrine Society, and again, highlighting again the need to switch patients who are on sulfonylureas to new medications like GLP-1, DPP-4, or SGLT2 inhibitors, because these are at a much lower risk of hypoglycemia. And now let's look what happens with sulfonylureas. Again, this is a meta-analysis showing a 3.5 increased risk of relative risk of hypoglycemic events compared to other medications. These are data from the TECO study using sitagliptin, and you can see there's the rate of hypoglycemic event in the events in the sitagliptin group is basically similar to what happens in the placebo group. Similar for dulaglutide, this is the AWARD 7 clinical trial with a much lower rate of hypoglycemic events in the dulaglutide group compared to glargine. And you can see here there is basically the rate of events is basically between half or 1/3 actually in the dulaglutide group compared to glargine. And if we compare dulaglutide in the REWIND study with the placebo, the rate of hypoglycemic events is basically the same. Similar for semaglutide, another important GLP-1, weekly GLP-1 produced by Novo Nordisk a couple of years ago. And again, the rate of events or hypoglycemic events is really similar between semaglutide and the placebo. Finally, empagliflozin. Professor Posilli was mentioning empagliflozin. Again, this is the EMPA-REG study. The hypoglycemic events in the group of patients treated with EMPA is basically similar, 1.4 versus placebo with 1.5. So basically it's the same. So no risk, no increased risk for hypoglycemic events in these patients compared to placebo. So I would like to conclude saying that hypoglycemia is the major factor limiting intensive control in type 2. Costs of hypoglycemia are grossly underestimated. They can cause severe morbidity and mortality and lower health-related quality of life. Patient awareness of the risk of hypoglycemia hypoglycemia with some antidiabetic therapy is very low. And it's very important, again, let me please emphasize the need of education, the need of spending time with patients in order to educate them to the management and prevention of hypoglycemia. Insulin therapy and sulfonylureas are associated with the highest risk of hypoglycemia, both alone and in combination. The replacement of sulfonylureas with new medications may significantly reduce the risk of this potential lethal event for diabetic patients. Thank you very much for your attention.
Thank you very much, Dr. Nicola, for this very clear and elegant presentation about hypoglycemia. Thank you very much.
My pleasure.
I give the mic to my dear colleague, Dr. Talat, to present the next speaker, please.
Bismillah ar-Rahman ar-Rahim. I have the honor to introduce one of the eminent speakers in our department. I have the honor to introduce one of the eminent speaker in our department, Professor كامل حميدة. كامل طبعا غني عن التعريف، MD MRCP PhD كذا حاجة. وبعدين دكتور كامل will talk about EDA Standard of Medical Care in Diabetes 2020. اتفضل يا دكتور كامل.
Many thanks, Professor Talal Ablati. Good evening, everybody. It's my pleasure to be with you tonight in this virtual symposium. My topic is about ADA Standard of Medical Care for Diabetic Patient 2020. Of course, I need like 20 hours to talk in details about standard of care in diabetes. But I hope that in the coming 20 minutes, I will give you a rapid summary about how to diagnose and treat diabetes and screen for its complications. So my reference will be the Diabetes Care Supplement 2020, January 2020. To start with diagnosis of diabetes, we have the ADA criteria. We have the ADA criteria of diagnosing diabetes: fasting plasma glucose more than or equal 126, 2 hours post-load glucose of 200 milligram per deciliter or more, HbA1c of 6.5 or more. Take care that any of these criteria can diagnose diabetes, so it is or, and even a random sample of plasma glucose of 200 plus symptoms of hyperglycemia like weight loss or osmotic symptoms can diagnose diabetes. Until 2018, the guidelines stated that in the absence of unequivocal hyperglycemia, diagnosis required two different samples from two results from two different samples. But from 2019 and 20, just one sample, you can take two readings from the same sample and diagnose diabetes. We know there's a stage preceding diabetes that's called pre-diabetes or increased risk. Fasting plasma glucose more than 100, 2 hours post-load more than 140, and A1C between 5.7 and 6.4. These are the criteria to screen for diabetes in asymptomatic subjects. And the ADA give us like a score that through which you can calculate the risk of how who are at high risk of developing type 2 diabetes. This score depends on the age, comorbidities like hypertension, weight, family history, and whether previous history of gestational diabetes. So what about the diagnosis of gestational diabetes and the definition of it? Gestational diabetes is glucose intolerance detected from the week 20, so it is the second or third trimester. So if you found a diabetic female in the first months or second months of pregnancy, this is not gestational diabetes. This is maybe type 2, type 1, or other form of monogenic diabetes. What are the recommendations to screen for diabetes in pregnant female? Test for undiagnosed type 2 diabetes at the first prenatal visit in those with risk factors using standard diagnostic criteria, and test for gestational diabetes at 24 to 28 week of gestation in pregnant women not previously known to have diabetic. You know, for gestational diabetes, after delivery we stop treatment. So if you are treating with insulin, we stop insulin, and then recheck after 6 to 12 months to see whether diabetes continued or resolved. How to screen for the females? It is the same criteria for increased risk of diabetes. Methods of screening for gestational diabetes are one of two strategies, either one-step strategy using 75 gram glucose. We take fasting reading 1 hour, 2 hours. If we have any of these values, you can diagnose gestational diabetes. Fasting more than or equal 92, 1 hour 108, 2 hours 153. The other strategy is a two-step strategy. We start by doing a 50 gram oral glucose tolerance test. It could be done non-fasting, and this is one advantage if you have the patient non-fasting. And if the readings is more than 130, you proceed to that step 2, which is 100 gram oral glucose tolerance test, and you need 2 of the following readings to diagnose gestational diabetes: fasting more than or equal 95, 1 hour 180, 2 hours 155, and 3rd hour 140. This is again one of the new additions to the diabetes guidelines and diabetes care standards. Starts from 2 years ago, that are the stages of type 1 diabetes. We used to have like pre-diabetes in type 2, but type 1, this was the first time to hear about stages of diabetes just 2 years ago. Stage 1, we have autoimmunity, but multiple antibodies, but no impaired glucose tolerance or no impaired fasting glucose. In stage 2, you have the antibodies and some dysglycemia in the form of impaired fasting or glucose tolerance or A1C. In stage 3, this is the new onset of hyperglycemia, so you have the antibodies and the symptoms and the diagnostic criteria. How to prevent or delay type 2 diabetes? Of course, annual monitoring in those with pre-diabetes is suggested. Lifestyle intervention, and we all know about diabetes prevention program that led to loss of 7% of body weight and led to, together with exercise for 150 minutes per week, and it shows marvelous results in preventing diabetes, even better than metformin. We could use again medical treatment for prevention of diabetes like metformin, and there are indications for that. You have a body mass index of more than 35, or those aged 60 years, or women with previous gestational diabetes. These are the main categories that will get benefit from giving metformin to prevent diabetes. Also, if you have a trending A1C like 5.9 last year and this year is 6.3, so you have an increasing A1C, this patient may benefit again from metformin, but take care in case of long-term use of metformin, you may check for vitamin B deficiency or give a supplement. In this category of pre-diabetes, they are at high risk of cardiovascular disease because the macrovascular complication may occur even before the true onset of diabetes. So you need to pay attention to that. The comprehensive medical evaluation and assessment of comorbidities include this, what's called patient-centered approach. Your aim to treat diabetes is to prevent complication and to optimize the quality of life. So you should have an eye usually on how to prevent complication. Okay, so you will go through this circle by assessing key patient characteristics like the current lifestyle, the comorbidities present at the moment, the current A1C. Then you consider specific factors that impact the choice of treatment by individualizing the A1C and the risk of hypoglycemia and the complexity of the regimen according to the patient, if he's illiterate or something like that. Then you should have a shared decision between you and the patient, and then you agree the treatment plan with SMART goals, and then you implement the plan, and then you have ongoing monitoring of what happened through implementing the plan to review any of these steps. Of course, you need to go past medical history and family history, lifestyle, medication and vaccination, make use of technology, behavioral, and a bit self-management skills to provide that to the patient, and physical examination. The lab investigation should not be glucocentric. We should look for the complications or the associations. So complications like assessment of renal function, associations like doing thyroid function in case of type 1 diabetes, vitamin B deficiency if with metformin, lipid profile to guard against macrovascular complications. So after giving the treatment to your diabetic patient, what are the glycemic target that you're aiming for? A1C testing should be done at least twice a year, and if the patient is uncontrolled, you may do it more frequently than that. Your target is an A1C less than 7 for most of the patient, but of course we will individualize that in the next slide. For the prebrandial measures, we need it to be from 80 to 130. For the peak postprandial capillary after 2 hours, we need it to be less than 180 milligram per deciliter. So these are the common targets for most of our patients non-pregnant. Again, these targets could be individualized according to these factors: the risk of hypoglycemia, the disease duration, life expectancy, important comorbidities, established vascular complications, patient preference, and the resources and support system of the patient. So according to that, you may relax the target or intensify it. Take care that the aim to individualize the target is to guard against hypoglycemia. We have 3 levels of hypoglycemia. Level 1 less than 70, level 2 less than 54, and level 3 you don't have a number, you just have any severe event, whatever is the number. The previous target is for those using the usual glucose monitoring techniques like samples, blood samples, or capillary samples, or glucometers. But what about those using continuous glucose monitoring and insulin pumps? We need new targets for those on continuous glucose monitoring. So that's what's called ambulatory glucose profile. So in this slide we have the green bar, what's called time and range. The amount of time that the patient spend within the proposed range, like from 80 to 180, something like that, or 70 to 180, according to the preset you put for your patient. So time and range, we need it to be about around 70. Time below range, this is the hypoglycemia. Time above range, this is represent the hyperglycemia, and each of which is further divided: the low 2 sections and the high 2 sections. So this is the new target, or the new form for those using continuous glucose monitoring. Now we talked about the approach and the targets and the lifestyle. So what about the pharmacological approach? What will you give to your patient? Of course, type 1 diabetes, the best thing is multiple daily injection of insulin or insulin pump. For type 2 diabetes, you have this famous algorithm: metformin, still the first line therapy for type 2 diabetic patient. Then we go through one of 2 routes. If your patient is at high risk or established atherosclerotic cardiovascular disease, renal disease, or heart failure, it is better to initiate the second step after metformin with GLP-1 or SGLT2 with proved cardiovascular and renal protection. If the patient does not have any of these, so you will make priorities in this specific patient according to: is there a compelling indication to reduce hypoglycemia, compelling indication to reduce weight, or the cost is a major issue for that patient? And according to that, you choose your drug. You start monotherapy, then dual therapy, then triple therapy. Some new evidence exists about starting with combination according to the VERIFY study. You may do that for getting better durability and better glycemic control and delaying the timing to initiate insulin. So we start by whatever strategy. You go till triple combination. So if you fail, you need to have the intensifying by injectable therapy. Previously we said intensify to insulin therapy. Now we say injectable therapy because we have short acting and long acting GLP-1 analog. you have the choice to intensify with any of them or a combination of this injectable according to the patient profile, the cost, and the affordability of GLP-1 in your locality. If the patient again is uncontrolled on basal only, you may further intensify to the basal bolus regime. And this is like a summary of different anti-diabetic agents and with their pros and cons, like side effects. The cardiovascular disease and risk management, I think Professor Iman has gone through that in details. I'll just give you some highlights rapidly. The target of blood pressure may differ according to the risk of the patient. So for those with 10-year risk score more than 15%, the target is less than 130/80. And for those with risk score less than 15, the target may be relaxed to less than 140/90. In pregnant, of course, you have some different targets, like less than 135/85. Initial treatment, if the blood pressure is less than 160/80, you may start with one agent. If it is grade 2 hypertension more than 160/80, you may start with 2 agents. In both cases, if you have albuminuria, it is better to give ACE or ARBs. If you don't have albuminuria, you have the free choice of any of these group, ACE, ARBs, CCB, and diuretics, because we have evidence that all of these can have good impact on cardiovascular protection. Lipid management, again, lifestyle for the initial management with like Mediterranean diet, DASH diet, encouraging fiber intake. For those aged 40 to 75 without atherosclerotic cardiovascular disease, use moderate intensity statin. For those aged from 20 to 40 with additional risk factors, it may be reasonable to initiate statin. For those at high risk, especially those with multiple risk factors and aged from 50 to 70, you give high intensity statin. If any age and the patient have established atherosclerotic cardiovascular disease, you give high intensity statin. And if you didn't reach the goal of LDL less than 70 with a single maximal dose monotherapy of statin, you may combine with ezetimibe or with PCSK9. Of course, statin therapy should be discontinued in pregnancy or for those preparing for pregnancy. What is the high intensity statin, and what we mean by that? It is the statin that reduces LDL by more than 50%. We just have atorvastatin 40 to 80 and rosuva 20 to 40. All others are moderate intensity statin that reduce statin by 30 to 49. Some new evidence that in patients with atherosclerotic cardiovascular disease or other cardiovascular risk factors on a statin with controlled LDL but elevated triglyceride, the addition of icosapent ethyl can be used to reduce the cardiovascular risk. Antiplatelet therapy, of course, for secondary prevention. Of course, we must give it for secondary prevention. For primary prevention, you may consider from 75 to 162 as primary prevention in those with diabetes who are at increased cardiovascular risk after a comprehensive discussion with the patient about the benefits versus risk. When choosing antihypertensive or antidiabetic agent for those with cardiovascular disease, consider protection. We said the aim of treating diabetes is preventing complications. So for hypertension, you consider ACE or ARBs. For post-MI, you give beta blocker. For those with heart failure, you may maintain metformin if the patient is stable with good renal function, but if unstable heart failure or eGFR less than 30, you stop it. And of course, you use SGLT2 inhibitors for renal and cardiac protection. For microvascular complication, just rapidly hints, again, because Professor Iman has gone through that, you should do at least once a year urinary albumin creatinine ratio and an eGFR. We start screening for type 2 diabetes at the time of diagnosis and for type 1 diabetes after 5 years, then annually. please do not stop the ACE or ARBs. If you initiate an ACE or ARBs and the creat does not jump more than 30%, do not stop it. So a jump of 10% or 20% is reasonable and acceptable, and on the contrary, it denotes good function of this newly added ACE or ARBs. Of course, these are the stages of chronic kidney disease. For diabetic retinopathy, it is the same. Glucose control and blood pressure control are of utmost importance, and you start screening immediately after diagnosis for type 2 and 5 years after type 1. For neuropathy screening, you do it using something for the small fiber and something for the large fiber. For the small fiber, temperature or beam break, and for the large fiber, you do vibration sense. 10-gram monofilament is mandatory that pick up those patients who are at increased risk of ulceration or amputation. Unfortunately, there is no preventive treatment for neuropathy apart from glycemic control. If it develops, you give symptomatic treatment. Food care, if the patient having loss of sensation, you should give education about prevention of foot ulcer and amputation, and the patient should have annual screening for both neuropathy and foot care. So I hope in the past 20 minutes we have gone rapidly through the different aspects of diabetes care, and thank you so much, and see you in the next symposium.
نشكر الأستاذ الدكتور كامل حميدة for this excellent and comprehensive talk, as usual. I have the honor to introduce the last speaker. مسك الختام الأستاذة الدكتورة نهى جابر، أستاذ مساعد في وحدة السكر والميتابوليزم كلية طب جامعة اسكندرية. دكتورة نهى one of the eminent cardio speaker in our department. دكتورة نهى will talk about statin in diabetes. If there is a best statin for diabetic. اتفضلي يا دكتورة نهى.
Thank you, Professor Talat Abdelati. Good evening, everyone. I hope you're all safe and fine. I would like also to thank Professor Fahmi Amara for his kind invitation for me today to participate in this CPD in my beloved IADA. Since I have been assigned this topic, statins in diabetes, there is a best statin, I have been thinking on the management of diabetic dyslipidemia and cardiovascular risk reduction. Should we adopt by now the concept of individualization or tailoring the treatment of our patients, the same concept that we have been adopting for years in the management of diabetes? And this concept has been adopted actually through all aspects of life, for example, through the technology, from all fits all until the personalization of our needs. And now I will mention two definitions: the precision medicine, which is customization of the medical decisions based on individual patient needs, and we will go through this to the personalized medicine, which is creation of new treatments in response to a particular patient's need. And the precision medicine concept has been adopted by the academia and the major healthcare providers for several years in different branches. So we are moving now from the concept of one-size-fits-all medicine to stratified medicine, where we have extreme, very high risk, moderate and low risk, and we are hoping to move to the precision medicine, where personalization according to the individual needs based on the behaviors and habits and the family history and biomarkers and so on. The prevalence of cardiovascular disease is higher in patients with diabetes. Here you can see the data from the CDC analysis, where they categorize the subjects into two categories: those with diabetes and those without diabetes. And after adjustment for age, you can see that patients with diabetes reported to be more likely to have a history of coronary heart disease and a history of stroke up to 3-fold compared to those without diabetes. In addition, they are about 2-fold times more likely to report other heart conditions. Not only that, I would like to here to show you the interesting results from the Hafner et al. Study, which was based on a Finnish population follow-up for 7 years. He categorized the patient into 2 groups, those with diabetes and those without type 2 diabetes. And then they were further categorized, those with a history of previous MI versus those without a history of previous MI. And to our surprise, those with diabetes without previous history of coronary MI attack had the same risk as those with the previous MI. So in our practice, when we see someone who's having type 2 diabetes, he's having the same risk like someone else who had an attack of MI. Higher cardiovascular mortality risk in patients with diabetes and low cholesterol than in patients without diabetes and high cholesterol. This shows that diabetes per se increases the risk of the cardiovascular mortality in spite of not having the same amount or the same level of cholesterol. At a lower level, they are even at a more high risk. And this is because of the main concept of the small dense LDL particles. Although we have 2 patients may have the same level of the LDL cholesterol, but if the patient is having diabetes, he's more likely to have small dense LDL, which means more ApoB, which means more atherogenicity. The cholesterol treatment trialist meta-analysis showed that on the long term, there is a linear relationship between the reduction of the LDL cholesterol and the reduction in the vascular events. There was 22% relative risk reduction, significantly per the LDL cholesterol among the groups. So for every 39 milligram per deciliter reduction in the LDL cholesterol, this reduced the annual cardiovascular risk by up to 28%, regardless of the mechanism. And we don't have any evidence of to what level the LDL cholesterol should go. So now we are adopting the concept of the lower LDL cholesterol, the better. And this has been shown by several landmark studies using statins, such as the TNT in the secondary cardiovascular prevention, the Jupiter using the rosuvastatin, and the PROVE-IT study using the pravastatin. On-treatment LDL cholesterol and the coronary heart disease events in statin trials has been confirmed at the level of both secondary prevention and also the primary prevention through several landmark studies. And this also has been adopted now in the recent decades with the new medications such as the addition of the ezetimibe in the IMPROVE-IT, the PCSK9 in the FOURIER and the ODYSSEY outcomes, showing that the lower the better, and now we are going down to lower than 55 milligram per deciliter, and in the extreme risk less than 40 milligram per deciliter. Professor Pozzelli has elegantly showed us the ESC and ES guidelines for the management of dyslipidemia. So I would just go through them quickly regarding the risk categories. Very high risk, especially I will focus on those who have documented atherosclerotic cardiovascular disease and on our patients with diabetes who have target organ damage or at least 3 major factors or early onset of type 1 diabetes more than 20 years. So when we have patient with type 2 diabetes who's reporting just albuminuria, this would put this patient in the category of very high risk patient versus the high risk and the moderate and the low risk. Let's apply here the concept of tailored medicine in the cardiorenal protection. We have Mr. Samir. He has type 2 diabetes and conferred albuminuria and CKD. The LDL cholesterol is 160 milligram per deciliter and has a strong family history of cardiovascular disease. So the LDL cholesterol, according to the European guidelines, is recommended as the primary lipid analysis method for screening, diagnosis, and management of this cardiovascular situation. And if we go quickly to the treatment goal for the LDL cholesterol, we'll find that in the primary prevention for individuals at very high risk but without FH, the LDL reduction of more than 50% from the baseline and reaching LDL goal less than 55 milligram per deciliter are recommended, level of evidence 1C. And even if this patient doesn't have albuminuria, but he's only having diabetes for a long duration, this will put him also at the level of a high risk with an LDL goal of less than 70 milligram per deciliter. So the option for our patient here will be high intensity statin therapy. Now, we have always faced the problem of benefit risk ratio in statin, and many of our patients, they are usually so much concerned about the potential risk, but we also have all the time to have the benefit to risk ratio in our minds, in our calculation, where the benefit of the statin is well established in the reduction of the LDL levels, reduction of the coronary atheroma, and reduction in the atherosclerotic cardiovascular events, where the potential risks are modest risk of new onset diabetes, muscle symptoms, and rarely clinically relevant liver injury, and potential increase in the risk of hemorrhagic stroke, which was suggested by Sparkle study, but it was not confirmed later. Also, we can't deny that statins have pleiotropic effects, so that's why the major landmark studies were on add-on to statin, like addition to ezetimibe or the PCSK9. Unless the patient is intolerant, we usually add these new medications with the strong evidence on top of statin due to the concept of pleiotropic effect regarding the improvement of the endothelial function, increased nitric oxide bioavailability, antioxidant properties, and anti-inflammatory effects of statins. Again, we go to the European guidelines for the recommendations for pharmacological LDL cholesterol lowering. We'll see that class 1A, it is recommended that the high intensity statin is prescribed to the highest tolerated dose to reach the goal set for the specific level of the risk. So the first choice is always high intensity statin. If the goals are not achieved, mean reduction of the LDL cholesterol in our patient more than 50% from the baseline, we can try to add on another therapy such as ezetimibe, which was well proved in the improved study. And in some situations, especially for the secondary prevention, level of evidence 1A, PCSK9 inhibitors will be added on top of statin and ezetimibe. So always the first choice for our patient is the high intensity statin, and Professor Kamel has shown us elegantly from a wide intensity of statin therapy how we categorize the different types of statin: high intensity, moderate intensity, and low intensity statin. For the high intensity, we have the atorva 40 to 80 milligram, rosuvastatin 20 to 40 milligram. So quickly I will go through the evidence of statins in the situation of Mr. Samir. The evidence of statins in diabetes. We have the CARD study. It's a landmark study which recruited around 3,000 patients with type 2 diabetes. It was a primary prevention regarding the cardiovascular, so these patients didn't have any history of atherosclerotic cardiovascular disease, but they had at least one other cardiovascular risk factor such as smoking, hypertension, retinopathy, or microalbuminuria. The LDL cholesterol level was less than 160, and the triglyceride level in this cohort were less than 600 milligram per deciliter, and they were actually randomized to either placebo or atorvastatin, but at a low dose of 10 milligram daily. And the primary endpoint was time to the first major cardiovascular event. To our surprise, it was prematurely stopped 2 years early due to the superior benefit for the atorvastatin 10 milligram, where there's a significantly 36% relative risk reduction and reduction of 40% from the mean baseline LDL of 117 milligram per deciliter. Again, I will go to the evidence of statin in CKD, like our patient Mr. Samir, who reported confirmed albuminuria and CKD manifestations. We have the SHARP, which is the study of the heart and renal protection. It was a major landmark study, recruited around 10,000 patients with CKD, but no history of atherosclerotic cardiovascular disease. Some of the patients were on dialysis, and they were randomized into 3 arms: arm with ezetimibe, simvastatin from the start, 10-20, arm simvastatin 20, and placebo for 1 year. After 1 year, The statin monotherapy group were randomized to either the placebo or add on to ezetimibe, and they were followed up for 4.9 years. The SHARP study showed relative risk reduction significantly of 17% in the ezetimibe simvastatin group, confirming the reduction of the major atherosclerotic events in these CKD patients. Also, the CARD CKD study showed the effect of atorvastatin on the kidney outcomes and cardiovascular disease in patients with diabetes, like our patient. And the atorvastatin treatment was associated in this study with a modest improvement in the annual change in the estimated GFR that was most apparent in those with albuminuria. دول أكتر ناس استفادوا those with albuminuria. The effect of intensive lipid lowering with atorvastatin on the renal function in patients with coronary heart disease, يعني even if our patient has established atherosclerotic cardiovascular disease, in the TNT estimated GFR result showed that estimated GFR improved in both treatment groups اللي كانوا على atorva 10 أو atorva 80 milligram, but was significantly greater with those patients on atorvastatin 80 milligram, suggesting that this benefit may be dose related. In this curve, you see a post hoc analysis of the TNT in patients with coronary heart disease and the CKD, and you will find here that there was 32% relative risk reduction in major cardiovascular events compared with the 10 milligram as a benefit for those who were at atorva 80 milligram. So in patients with CKD, and atorvastatin 80 milligram resulted in significant reduction in the secondary event rates. كانوا لصالح الأتورفاستاتين 80 milligram. وده it wasn't at the expense of the safety in patients with CKD when compared to those with normal estimated GFR regarding the hematuria, the albuminuria, the elevation of the CPK, or elevation of the liver enzymes more than threefold the normal. Finally, I will go through the Planet 1 and Planet 2 study. The Planet 1 included patients with type 1 or type 2 diabetes, while the Planet 2 included those without diabetes, but the inclusion criteria recruited those with moderate proteinuria, hypercholesterolemia, and already on ACE or ARBs for more than 3 months prior to screening. So these patients were taking all the precautions to reduce the proteinuria, and they were randomized into 3 groups: Ruzuva 40 milligram, Ruzuva 10 milligram, atorvastatin 80 milligram. The primary endpoint in the Planet was the effect on proteinuria. So versus baseline, atorvastatin 80 milligram significantly reduced urinary protein ratio, while rosuvastatin in this study of the 40 milligram demonstrated no significant change in the urinary protein ratio. The secondary endpoint was assessment of the changes in the estimated GFR. So in the Planet 1, the patient on Ruzuva lost more kidney function over the 52 weeks of the study versus the atorva arm, and the rosuvastatin 40 in Planet 2 significantly decreased the estimated GFR versus the baseline. And here I'm showing you the summary of the reported adverse events, which were non-significant among the 3 groups, but the acute renal failure and the serum creat doubling, the doubling of serum creat or acute renal failure, were significantly lower in the atorvastatin arm. So the Planet concluded, the conclusion of this study, that in people with or without diabetes with proteinuria, the Ruzuva 10 or 40 milligram had no effect on the proteinuria, whereas the atorvastatin improved or reduced the proteinuria. Ruzuva 40 was associated with significant decline in the estimated GFR, where the atorva 80 showed no change in the estimated GFR. With respect to statin-induced renal protection or renal damage, atorva 80 had a clear advantage and evidence according to the results of the Planet over the Ruzuva 40 in the studied renal patient populations in this study. To summarize, the LDL cholesterols remain the primary target for therapy in most strategies of dyslipidemia management. Even lower LDL cholesterol is even better for the cardiovascular benefits. There is no distinction between primary and secondary prevention management. The recommendations are similar for a similar level of risk regardless of whether the patient has had previous event. The treatment should be based on the best available evidence and personalized according to the individual risk and need so that we can get the best statin for every patient according to his situation. And thank you.
For this excellent presentation as usual. Professor Nicola, again, the question from the beginning. The first one, does glucophage can cause hypoglycemia?
ما في خلاص احنا خلص.
Hypoglycemic events in patients on metformin are much less common and are basically the 1-2% of the total of hypoglycemic events. It's a medication that usually doesn't cause any hypoglycemia. That's why we usually give metformin also to patients who are not diabetic, like patients with PCOS or with insulin resistance. It is not a medication that usually gives hypoglycemic events and mostly doesn't give any severe hypoglycemic events.
The second question, does glucophage can help in reducing weight?
Well, maybe the side effects of metformin because of sometimes the GI effects like nausea or some GI effects may help to reduce weight, but it's just a side effect. Metformin doesn't have a direct effect on losing weight.
The last question, which level of glucose can lead to loss of consciousness?
Sorry, I didn't hear the question.
Which level of blood sugar يعني can lead to loss of consciousness?
This really depends from a personal threshold of hypoglycemia, and it really depends also how used is the patient to hypoglycemia. Patients who have frequent episodes of hypoglycemia have a lower threshold to be, to become unconscious. So basically, this is the worst situation because sometimes they feel hypoglycemia just when it's too late. But usually is under 60 or under 54, actually, according to the ADA threshold classification. But again, it's really personal. So there are different, each of us has a different threshold for reaching asymptomatic hypoglycemia.
Thank you.
My pleasure.
Thank you. أستاذ فهمي حضرتك كلوز. أستاذ فهمي صوت مش مسموع.
We end our meeting now and we thank our speakers, Dr. Pozzilli and Dr. Nicola, and our friends. Thank you. Have a good night. And we have to thank Pfizer and all our national speakers, Pfizer and ICOM, and have a good night and good dreams. Thank you very much.
Thank you. Thank you.
Good night to you.
Good night.
Thank you.
Good night.
Arrivederci, professore.
شكرا.
Arrivederci. Bye. Bye, family.
Arrivederci.
Bye-bye.
Bye-bye.